Welcome, everybody. I'm really pleased that you are here to join us this evening at the Calman Lecture. My name is Jackie Hayden, and I am president of the Academy of Medical Educators. And it's a great pleasure to be hosting the event this evening. In advance of the evening, can I just take the opportunity to thank Tony, Jodie, Paul and Claire and everyone else who has contributed to ensuring that this event was organised as it has been. And I am sure it's going to be a great success. So welcome to the Calman Lecture. This is a prestigious annual event, and it's held each year in honour of Sir Ken Calman, one of the founders of the Academy, as a tribute to Ken's enormous involvement, leadership and contribution to teaching, learning and the organisation of medical training and education. The general theme for the Calman Lecture is reflections on medical, dental and veterinary education. Former Calman lecturers have included author and broadcaster Bill Bryson, Chancellor of Durham University, Lord Crisp, co-chair of the All-Party Parliamentary Group on Global Health, Sir Terence Stevenson, Chair of the General Medical Council, Professor Jenny Hyam, Chair of the Medical Schools Council, Peter Lees, Chief Executive of the Faculty of Medical Leadership and Management, and last year, the Academy's 15th anniversary, Sir Ken Calman himself was interviewed by two of our early career educators, and the video is still available on our website. I'd like to say a few words about the Academy for those of you who may not be aware of what we do and what we stand for. And I hope that if you are inspired by this evening, you will go and have a look at our website and read a little bit more and see how to join us. The Academy of Medical Educators was established in 2006 and is a charitable organisation which exists to advance medical education for the benefit of the public. It is the professional organisation for all those involved in the training and education of doctors, physicians associates, dentists and veterinary surgeons. The Academy is the standard-setting body for medical educators in the UK. Its professional standards, which have recently been revised, define the level of competence that medical educators should achieve at each point in their careers. The standards provide a recognised framework for professionals to demonstrate expertise in medical education through accreditation as a medical teacher. Recognition by the Academy demonstrates skills and competence when applying for revalidation, promotion, and approval as a trainer. The Academy now has over 1,200 members across the UK and beyond, and each benefit from access to a network of medical educators for every level of career progression, regular newsletters, mailings, and updates via the online community. A programme of academic meetings and events, including the Insight series and the annual Calman Lecture, which is taking place today. And also our national conferences and special interest groups. And the Academy has a series of awards and prizes. Tonight's event, we will come to in a minute, and what I'd like to do is encourage you to ask questions of our speaker by typing in the Q&A box. You can use the chat box if you like for anything that you might want to say, but it's much easier for us if you use the Q&A box, which you can see on your toolbar. I, together with Academy colleagues, will monitor the questions and then put them to the speaker on your behalf. So you can use the Zoom chat, but please be aware we won't be reading out any questions that you put in the Zoom chat box. So tonight, before we begin the lecture, I have another important job to do. It's traditional to award the President's Silver Medal at the evening for the Calman Lecture. Because of the pandemic, this has been postponed or put in abeyance over the last few years. So it's a real pleasure that tonight we are going to celebrate this year's award winner. The President's Medal is presented to an individual who has made an exceptional and sustained contribution to medical education and who will not usually have achieved recognition previously by other medical education organisations. The recipient will not normally have been recognised by another medical education organisation. In particular, the President's Medal will only be awarded to individuals who demonstrate the values of a medical educator and promotes the aims and objectives of the Academy, who have made an outstanding and sustained contribution to medical education through at least one of the 5 domains in our standards for medical educators, and who have not been recognised by other medical educational organisations at a national or international level. This award is one of the highest conferred by the Academy of Medical Educators. It comprises a silver medal and a certificate. Tonight, it gives me very great pleasure to award the silver medal to a member of our council. And in a minute, I'm going to ask her to turn on her camera so that we can congratulate her. The award this year is going to Claire Stocker. So Claire, could you please turn on your camera? Dr. Claire Stocker is a healthcare scientist by background and is currently the Phase 1 lead for Aston Medical School, MBCHB, and senior lecturer and honorary reader for the University of Buckingham. Previously, she was a member of the programme executive that instituted a new medical school at the University of Buckingham and developed and led a dual accredited PG Cert Med-Ed. Her research interests are developing professionalism in undergraduate students and e-portfolio learning, publishing widely in internationally recognised journals. She's a member of the Medical Schools Council Committee for Professionalism and a member of ASME Medical Educators Involved in Student Support Group. Claire is currently chair of the Academy's Education Committee and has developed and supported educational activity in the Academy to a degree that is unprecedented. She has supported the development of our Young Educators Group, DMEG, activity and established our Insight series, as well as masterminding 2 very successful conferences and taking a key role in our membership to fellowship workshops. Claire is someone who richly deserves the President's Medal. Her talents and contribution have frequently gone unrecognised, and she has been very slow to take credit for the fantastic work that she leads. Congratulations, Claire. So perhaps we might somehow or other recognise, good, we have got some clapping hands. For those of you who may not know, Claire was, I hope, completely unaware that she was receiving this award tonight, and we're absolutely thrilled. So well done, Claire.
I'd just like to say, President, thank you so very much. I'm absolutely speechless. But I've learned so much from working with you all as my mentors, and it's been a fantastic journey, and I'm really looking forward to my next term of office as the chair of the Education Committee. So thank you very much indeed.
Thank you, Claire, and we're looking forward to your next journey as well, and we're excited to be with you. So thank you. And now to the Calman Lecture. We are very excited that tonight, for the first time, our Calman Lecturer is primarily a dental educator. He is Professor Barry Quinn. And I'm not going to read out all his qualifications because I think we might be here till tomorrow, but suffice to say, they don't fit on one line of my text. He is Professor of Restorative Dentistry and Dental Education and Honorary Consultant in Restorative Dentistry and Academic Lead and Head of Restorative Dentistry at the University of Liverpool, the School of Dentistry and King James IV, Professor of the Royal College of Surgeons of Edinburgh. Barry is presently Secretary General of the Association of Dental Education in Europe, President of the British Alliance of Researchers in Dental Education and Scholarship of Dental Education and Scholarship, Co-President of the Dental Teachers of Professionalism in the UK, and a past President of the Education Research Group of the International Association of Dental Research and Metropolitan Branch past President of the British Dental Association. He is also a Dental Council elected member for the Faculty of Dental Surgery at the Royal College of Surgeons of Edinburgh. In 2017, Barry was the main lead for the Shaping the Future of Dental Education World Workshop held at King's College London. He is also a past recipient of the ADEE Mature Educators Award in 2013 and Interprofessional Educators Award 2016 and the American Dental Education Association Emerging Leaders in 2021. At the University of Liverpool, Barry leads the integrated teaching of restorative dentistry for the collaborative learning core for the interprofessional education of dental and dental therapy students. His main research has included interprofessional education, haptic virtual reality surgical skills education, and he completed a PhD in this area at King's College London. He has been fortunate to win many UK and international awards, such as the Medical Futures Award in 2011, British Education, Technology and Trade Awards for the Innovation in Education with his colleagues in the Haptel team, and in 2020, a King Civic Challenge Award working with the Borough Food Corporation. Barry has published over 180 peer-referenced in reference publications and abstracts. I feel absolutely humble reading out such an extensive citation, and we are honoured indeed that you are joining us tonight, Barry, and I'm now going to hand over to you.
Okay, thank you. I will try and share my screen. Let's see if that will move. Yes, that will work. Okay, this is a great honor. Thank you. I feel very humble with such a fantastic introduction to follow this. And I do hope that this will be of interest, not just to dentists, but to the wider healthcare team. And I've included some examples. So to no further ado, I will continue. I'm going to be talking on the haptically enabled virtual reality simulation and about the future of surgical skills training. The learning outcomes is I'm going to summarize some of the important benefits of haptic technologies used in contemporary simulation, understand the potential and some of the limitations of haptically enabled environments for psychomotor skills, and discuss some of the evidence available for simulated practice in education, and also question how real does the simulation have to be. First of all, looking at this image, I just wanted to remind you that the sense of vision is very important in all simulation. By watching this image of somebody's hand going through a wheat field, you can almost feel the image. And this is very important to make it immersive, but haptics adds the additional sense of touch. Simulation is a necessary component for professional skills acquisitions, such as surgeons, dentists, etc. And it's no longer acceptable or appropriate for students to be practicing new skills on patients, even if the patient has given explicit consent. Surgeons, just like the violinist, need many, many hours of deliberate, repetitive practice. But this practice needs to be purposeful and systematic. It also needs to be focused to improve performance. Otherwise, the performance will not improve. Standard learning in dentistry, and this is true of our surgical colleagues, is that most of our students start with the theory, the bookwork. In dentistry, we traditionally practice on phantom heads with either plastic or extracted teeth, and then eventually on to patients once we've passed a competency test to show that we are safe to be let loose on patients. But with dentistry, this happens with the undergraduate program, but they're very closely supervised by qualified colleagues. So why change current practice? Well, there's unrelenting pressure to update and reform teaching. There's increasing societal pressures for patient safety. Patients are less willing to be guinea pigs for trainees. And there's also ethics about students working on each other. Traditionally, dental students and my generation, we practiced injections on each other, but that's no longer acceptable. There's also fewer suitable patients for trainees due to the complexities of medical histories. So trying to find suitable, relatively good patients for novice students is getting more challenging. And there's fewer suitable extracted teeth in dentistry. Teeth are only extracted if they're generally very broken down. Also, there's challenges in all health professions in recruiting teachers. Many teachers are retiring. And our students and trainees now expect the latest technology. Generation Z have been using this and don't remember the time without even a mobile phone. Also, we do need to consider human error, reducing error from surgery by doing surgery rehearsal. And this is quite an old statistic, but approximately 250 million will undergo surgery. 7 million will suffer complications following the surgery, and 1 million die as a result of the complication. So we want to improve this sort of figures. Human factors. I'm going to discuss, this is primarily from high performance skill acquisition in the aircraft industry. They were the ones who started doing the human factor error and trying to reduce it. So we frequently say practice makes perfect. Well, it doesn't if it isn't challenging and if it isn't got good feedback and it doesn't actually result in improvements. A lot of students like practicing easy exercises that give them high scores that massages their ego. So we need to keep challenging them. We also say we must train for the total skill. But from the aircraft industry, they don't. They train maybe taking off, landing, turning, and then integrate it. And that by disassembling the procedure into small bite-sized pieces, the students can then learn to do certain difficult with certain easy and then integrate it. We traditionally say skill learning is intrinsically enjoyable. But if any of our listeners have learned to play a musical instrument, they know that it took many hours of repetition before it became enjoyable. And we talk about training for accurate performance. Now, that is true if you're an airline pilot. You would not be very happy if the announcer before landing said, I got 80% of my landing tests, because that would not be sufficiently accurate. But 80% may be for certain medical procedures. So we need to consider what level of accuracy is the level we need to achieve. We used to think initial performance was a good indicator or predictor of success. Now, that is only true of very simple exercises. The more complex the exercise, that challenges everyone. so it's not a good indicator. And also we used to think once concepts have been learned, proficiency will develop. Understanding and eye-to-hand control are very different. Somebody can actually be able to talk you through a procedure, but may not be able to do it. So what's haptics? Well, haptics pertains to touch. Force feedback devices afford the sense of touch to virtual reality images. So why are we using haptics? Well, as we know, medical staff frequently have to perform dexterous exercises, which require simulation and training. We are challenged with some of our dummies and some of our ways in order to give a realistic form of simulation. Haptics adds to this sense of realism. So which areas are using haptics? Well, not just dentistry, there's endoscopy have been using haptics for a number of years, and so is laparoscopy and minimally invasive surgery. Orthopedics, which actually shares a lot with dentistry, it's just dentistry is using drills at a much smaller scale than our orthopedic colleagues. And of course, dentistry. I've been involved since 2007 in developing some of these simulators. So what are the tasks that are frequently being used? Well, suturing has come in, and that's useful for many of our professions in healthcare. Also palpation, feeling lumps and bumps, teaching somebody what is lymphadenopathy, and also palpating organs. Our veterinary colleagues have been using the haptic cow, and I worked with Sarah Balian, who was a vet at Bristol at the time, and I think previously at Glasgow, and she developed the haptic cow. And I'm sure there's been lots more development in haptics and veterinary medicine. And of course, dental drilling, which has been going on for now at least 14, 15 years. And orthopedic drilling, which is very similar to dental drilling. Cutting soft tissues is also very useful. The problem is if you have orthopedic surgery that requires soft tissue and hard tissue, this can be a challenge for the haptic devices. It's usually easier to have one for hard tissues and one for soft tissues. So what are the opportunities afforded for our trainees? Well, obviously deliberate practice, which is important. Also, we can give them simple exercises to improve their psychomotor skills. In dentistry, we need to teach mirror vision or reverse vision, which can be incredibly challenging for the novice. The machines give objective assessment, so less hawks and doves from the teachers. And it allows an independent practice, so they are not using sharp instruments, so they're in no danger. Also in dentistry, we frequently pair them, so they've got a peer to help review and discuss their learning. And it gives objective feedback, frequently scores, which may not always be as realistic, but in certain exercises, if you have to remove something by 100%, at least you know how close you are getting to removing the 100%. And in dentistry, we do not have to use plastic or indeed real teeth, which are beginning to become difficult to find. The plastic aerosol is not healthy either for neither the student or the staff. So plastic teeth is not a good solution either. And of course, the systems now have case presentations with history, radiographs, etc. And during COVID, there was no aerosol, though it gives the illusion of a water spray and aerosol. So it was a very safe environment to teach in. So that was the other thing. So there's less tutor time required, able to review procedures by the tutor. So this is for the trainers, and we can compare peers. Frequently, the tutor can sit at a desk and see what the students are doing and seeing who is doing how many exercises, how long they're taking, and what sort of scores they're getting. So they can monitor the usage. So frequently you can actually illustrate to a student or a trainee that they've done less practice. And it's easier to monitor progress. The data is objective because it's been given by the system. We can increase complexity of the tasks, so we can start with simple tasks, go into for the more complex ones. And we can now also do remote supervision, just as like I'm giving you this lecture remotely. And again, no aerosol. So what are the challenges with assessment? Now, this is true of all assessments. Tutors are beginning to stop failing. I'm not saying that we should be aiming to fail, but maybe we need to start considering giving objective feedback. And that's exactly what these systems do. They give assessment and feedback independent of the teacher. And there's many papers written on this, and this is just one from the European Journal of Dental Education. So why is there resistance to adopt haptics? Well, we all know what it's like using technology, and even before this lecture, I came on early to make sure I could actually share my screen, because you always have that dread of, oh my God, it might not work. And I can understand that. So we need to gain confidence. Some people think the technology is not there yet, but I will show you, if you always wait to the technology be perfect, then you'll never use it. And also there will be resistance from traditional members of staff who say, why bother changing? And of course, there's the technophobe who really dreads using it. And also some staff are beginning to wonder, will I be without a job? If your job is primarily to educate and train, and the answer is no, we will still need human interaction. This is just an adjunct to our teaching. So with new technology, as you can see, I was probably an innovator early on. Most are probably now the early majority. But if you keep waiting for the technology to get better, then you'll always be waiting. So you do need to dive in at some point. However, just to control your enthusiasm, when you start, there's usually overinflated or a peak of expectations. And it is normal for the teachers then to go into the trough of disillusionment, where they suddenly go, oh, this is too complex to understand. But what I have found is the students learned the technology very easily and frequently taught the teacher how to use it. So we get the slope of enlightenment before we end up being productive with these systems. There's lots of haptic startup companies happening, and these are just 3 of them, such as they're also going beyond education. They're beginning to educate the patient's muscle, so post-stroke. There's also more surgical simulators coming in, and Tesla's dividing a Tesla suit. So that might be able to help move parts of the body if there's any injuries. There's also haptic gloves coming in, and this will help to palpate, but also possibly help to guide students. And indeed, remote surgery is being considered by various militaries, such as the US military, to help guide people. If they're on a war field and they've never seen a procedure, they might be guided from somebody from a Los Angeles hospital. Haptics is not just about simulation, but I will be going on a little bit more about the research. But I worked with Professor William Harwin from the University of Reading, and his research was on exoskeletons with haptics to help stroke rehabilitation. So it's going beyond the trainee and now on to the patient. I'm just going to include a few medical before I go on to more dental. But there's various ones coming on for virtual reality surgical training with kidney surgery, laparoscopy, and there's many companies, and it is actually very well researched now. And the evidence is there that laparoscopic training does improve before you do it live on a patient. I'm going to start and show one video as well. And I hope you hear it. Okay, so what you could see in that was that they were using a haptic glove to actually palpate and feel, and they were using another haptic device that simulated the surgical drill in orthopedic surgery. So double-handed, oh, I'll move on. Double-handed haptic devices are coming onto the market. Dentistry, this is a traditional phantom head room where the students are paired off, and you come, I'm hoping you can see my pointer. There's a phantom head just hiding there. That's a dummy or a mannequin in which we either put plastic teeth or traditional extracted teeth into the phantom heads. This is way back. This was published in 2010, but was developed in about 2007, based on 3D TV technology at the time, where the student would have to wear goggles, but they would see a 3D image and they could actually feel the image and could do some surgery on it. They've now got better. So these are some of the systems that are coming onto the market. The Nissan is probably been the longest commercial product, but it's quite a small screen. You can see that it's just not much bigger than a hand. Now, you could say it's replicating the mouth. So it's very dentally focused and cannot be applicable to other areas. This is a French system, Vertisi, which is again based on 3D TV technology. And it's a wider screen, so they actually can do larger operations. And I think they've gone into veterinary medicine as well. This is the one that we've got at Liverpool. It's from a Dutch company, and it's a mixed reality. What the students do is there's still a traditional phantom head. However, they look through the screen and it superimposes pathology. So there's a different sense of real touch and haptic touch. So this gives a more immersive environment for the educational learning of the student. They can choose a number of exercises. In dentistry, you can see there's various operative, prosthodontic, endodontics, etc. So it's really useful for adding to curricula. And that's what was lacking previously. We just didn't have enough exercises. I'm going to show you now an ID block being given. I will say for my dental colleagues, the student hasn't given it in the correct place. It should be a little bit more lateral, but please do look. So the student can feel it going into the soft tissues, and they can feel the syringe and giving the local anesthetic. And this is really useful because previously they used to practice on each other, and now they're no longer allowed to do that. And we only either use plastic dummies, which have been used so often, it's so obvious where you have to inject. So with this, you can change patients, you can change the anatomy, you can have children. So it's a really useful way of teaching. I'm going to start another one, which is drilling, and I'm hoping you can hear this as well. It takes a moment, the student's just feeling the tooth. This is a floating tooth, we would say, or a handheld tooth. This is early days before we put it into a jaw to make it a bit more complex. So there's a mirror, so they learn to cut in reverse vision. And I hope you can hear the drill, and you can see that it even replicates the water spray. So I'm just going to move on to the next one. So this is another dental procedure. This is a crown preparation. That is when you remove the outer surface of the tooth for maybe a gold or a ceramic crown. Dentistry is very precise. I'm sure the dentists will know that. We're talking about fractions of a millimeter frequently. And again, the mirror comes in to teach the student in reverse vision, which can be incredibly challenging. I will move on from that. This is one of the psychomotor skills. Very early on, we teach the students, just remove the balloon. Now, this student is showing you that they can feel this virtual image and they can slip off it. And these exercises come in different shapes, but it's just teaching the student. We give them a target of 96% removal of the blue. Try not to remove too much of the leeway, which is the edge color. So we'll move on. And another dental exercise before. This is teaching periodontal probing. The student learns what pressure to exert by just touching a tooth before they look at the gap between the gum or loss of attachment. And again, this is very difficult to teach clinically because some students will be very light, some will be more heavy-handed. And we can start teaching removal of calculus below the gum. So I will move on. And the last one for the dental is dental implants. Now, with the dental implants, we can actually haptically activate or enable cone beam CT scans of patients so they can do surgery rehearsal before they do an implant procedure. And that's important because the ID nerve is frequently, or is at risk of being damaged with incorrect surgery. So you do want to know where the nerve is. And you can see it looks red as if it's bleeding, and you can try out and then put the implant in. Okay, I will move on. Other systems is third molar systems, the porcelain system, and this is a mixed reality in that you can see that there's still a plastic head, but they're looking through the screen and superimposing the pathology. This is an injection system that we developed at King's when I was at King's, that we did try out with medics. It did involve the Oculus Rift glasses, and you can see the haptic device. But what the individual saw was a surgery. They would see the patient coming in. The graphics are now getting much more realistic rather than possibly these cartoon characters. But they would see the patient opening the mouth, and they could peel back the anatomy, and the anatomy is getting far more detailed, and they could see where the ID nerve is. So it was very useful educationally for the students before they ever did this on a real patient. So where is the evidence, and are these skills transferable? Well, they are, in that the flight simulators, all pilots have to do haptic simulation in flight simulators, and they learn to land aircraft in very difficult airports, such as Madeira and Funchal and the old Hong Kong airport. The laparoscopy studies now have been going on for nearly 20 years, and they're showing dramatic improvements. And I would say the dental studies now are coming out to show that the skills are transferable. And I will be discussing one of the studies that I was involved with. This was the HapTel team. It was Haptics for Technology Enhanced Learning. And they came from the University of Reading, King's, and Birmingham City University. But it involved a lot of people from different disciplines. My PhD was done in this area, and it was basically saying there would be no difference between a traditionally trained group and a haptically trained group. We looked at 144 year one students, and because we couldn't afford many of the devices, we had to divide it approximately 2/3 to 1/3. So we trained 1/3 on our HapTel machine and 2/3 on a traditional. Now, in order to get ethical approval, we had to do it on year one students, and we had to do a crossover study. So after we had done our test, both the students crossed over and they both had the same experience by the end of the year. We replicated plastic teeth, which had different types of carious cavities at different depths in the haptic environment. So we had a task 1, 2, 3, and then we made everybody do a traditional assessment and a phantom head. So the students who'd only used the haptics, we wanted to see, could they go in and use a normal handpiece and operate in a phantom head environment. I don't expect you to read this quite complex diagram, but it shows basically how the sessions went. They had 1, 2, 3 sessions. So they had 3 mornings practicing the procedures. Then we made them do a traditional phantom head test. I also collected in the plastic teeth, and I also micro-CT'd them. So I was able to get further details about roughness, volume removed, etc. But in simple terms, the results showed that the haptically trained performed equally as well as the traditionally trained. They may have performed a little bit better, but because the plastic teeth were so expensive, we had to limit the number of attempts in the phantom head, while haptically they could have stopped and started as many times as they wanted. The haptically trained students were able to go straight into a traditional clinical skills laboratory, lift a handpiece, use it, and operate on the tooth. So those skills were totally transferable. And the micro CT imaging was a novel assessment of the volumetric and roughness, but that would be a totally another talk, and I won't go into that. So psychomotor are eye-to-hand skills. Well, when we use these systems, we need to deconstruct the tasks to learn the stages. We need to separate motor skills from understanding. And we need to try and have synchronized movement of both hands. Now, this is very important in dentistry, where they have to hold a mirror and hold the actual handpiece. And the complexity of the task can be increased as skills increase. Here is a very simple diagram of one of our psychomotor tasks. We ask the students to remove the blue color, and we ask them to get 96% removal of the blue. And we try to say, we do not want you to touch the leeway, but if you do, touch no more than 7%. And then there's an off-white color, which is the base color, and we say, try and not to touch more than 1%. So we did this. It was a non-interventional retrospective study that didn't require ethical approval because it was part of the normal program. So our goals for mastery, as I said, was more than 96% are equal to less than 7% and less than 1%. And I compared year 3 students to year 5, and none of our year 3 students achieved all 3 parameters. However, almost 50% of our year 5 students achieved these parameters. So that was good, that it showed that practice did improve. We also showed that the 5th years were significantly better than the 3rd years, which is reassuring. It was at the beginning of year 5, so they still had a whole year to improve. And the simulators, the student feedback was that they actually liked the feedback and liked the fact they could practice in a safe environment. Other immersive technology that's coming in, HoloLens. So you can see images such as this, where the surgeon may be looking at a spine. The one I've got was at Amy, and I was being able to manipulate objects and move things. So it was quite strange. But they're developing glasses so that people who are living at home, who may have dementia, it may flash up in the glasses, reminders of things to do, take your tablets, etc. This is an example of a Syndicare device for surgery rehearsal, actually in a dental surgery. This is ACTA, the Dutch dental school. So the students can take images of the teeth they're going to prepare, haptically enable the images and the radiographs, and practice before they do it on a patient. But haptics is not the only technology that's coming in. And I'm just going to show you in a moment another example of other technologies that's coming in. This is a robot. This is from a Japanese company, but to be honest, it looks a bit scary. I don't know if I'll move on. I don't know if I'd like it to be that real. And in fact, the robot can talk to you, but it's talking in Japanese at the moment and things. So how real does the simulation have to be? Well, fidelity in simulation. Fidelity refers to the sensory resemblance. That's auditory, visual, and tactile. If you ask the teachers, they're always demanding that it doesn't look real, it doesn't look like a patient. Then we also got to think of the functional resemblance. What we're using it for, and that depends on the context and the learning. Does it resemble the exercise? Too often, face validity, that is what the simulator looks like, is criticized. But for junior students, it's usually sufficient so that they develop eye-to-hand control, develop procedural order, and actually are still learning. So, from the research, one of the criticisms of dental simulators is they do not feel like real teeth and caries. So Sharon Graydon's team looked at 20 of her staff, and she got 20 dentists, very senior experienced dentists, and said, I want you to tell me by removing a softness in a block when you would stop removing the caries. This is a challenge. The dentists out there will know this, is how much caries should you remove? And she found of her 20 staff, 10 of them were reasonably close and 10 of them were all over the place. So she said, is the criticism of these systems possibly to do with the teacher? Now, it may be that the sense of touch varies just as much as other senses. We can correct eyesight and hearing, but maybe we need more practice to improve, yes, the eye-to-hand control, but also texture, which is very important in dentistry. And what I found was that for novice learners, you do not need complexity. You start off with very simple deconstructed exercises, and you only need to add the complexity with more experienced postgrads. So it doesn't have to be that realistic. So our very experienced surgeons will be critical of it, but not realize that our novices are still learning from it. There's also been some criticism, but this is a little bit out of date. It's 2012, 10 years ago, and that was that some of the instruments needed further development. And I think we've now got a lot more instruments and a lot more pathological cases in these systems. So what's the future going to be? Well, we are going to be adding artificial intelligence. That might mean is that before you do a procedure, you'll be able to ask the machine their medical history. What's the reason for attendance? They will be able to give intelligent answers back. We might be able to palpate lymph nodes, and with dentists, things like the temporomandibular joint. We can have a range of diagnoses, and things like in dentistry, orthodontics, we might be able to visualize tooth movement so that we put on orthodontic braces in a haptic environment and see how does that affect the movement of the teeth. There's going to be a greater range of surgical procedures, and remote training in surgery is going to become great potential, so that in certain areas you may have your students in rural outreach areas and still teach them if they've got a haptic device, and I could give a remote lecture. The companies do want to work with universities and develop the tasks. So if there's anybody out there interested, either make contact with myself or anybody else. And just for disclosure, I have no financial interest in any of the companies I've shown. Haptics is coming into surgical robots. So the Da Vinci system is now, and you can see in this case, the surgeon is usually remote from the patient, although there's no patient here in this example. But previously, they moved the instruments with the robot's help, but they couldn't feel it. But now they're developing haptically enabled robots. So the surgeon is guiding the robot and actually can feel the tissues. Just some confounders. I'm not going to be talking much longer, so I'll be trying to finish by 6. The confounders in published dental simulation is different tasks are frequently performed, which makes difficult comparisons in the papers. Ethical constraints mean it's very difficult to get true randomized experimental control group studies. And we must remember that early adopters of new technology are usually enthusiasts, and they potentially report biased results. And also, enthusiastic teachers get good results anyway, no matter what way they teach, and we must always remember that. I'm coming to an end. I just want to say, if any of my dental colleagues or my medical colleagues, AD, the Association of Dental Education of Europe, will be hosted in Liverpool in 2023, the 23rd to the 22nd of August. And the theme is collaborative education and a digital era. So there will be lots about this, but also interprofessional education. These are some of the references, and I'm happy to share any of the references or any of the slides. And I'd like to thank you for listening. It's been a pleasure and a great honor. Thank you.
Barry, thanks very much indeed for an absolutely splendid lecture. And I think you can see the congratulatory hands coming up. Absolutely stunning and incredible, the progress that we have made and that you've brought to life. I had a little feel of it through some of my other activity working with Tony Young and the entrepreneur team, and it would be good to connect up there. Now, I think you've stunned the audience into silence. There have been no questions coming up. I will keep an eye on the chat, but there's nothing coming up at the moment. I guess for me, if I might take privilege as the chair, what I am concerned about with the pandemic is that we've got surgeons who have been trained and they have entered their surgical career, but actually because of the pandemic, and then because we're dealing with the throughput through the front door, through the emergency department, they've not been able to do the operations. How real is this going to be? Could we have something so that the surgeons who may be a little bit uncertain about the operation that they're going to do next week or tomorrow could go and rehearse in advance? How real is it to get it there, or is it going to be just in centres of excellence?
Interesting question. I mean, one of the challenges is that these devices are expensive, and things that I didn't show is you can practice cataract operations, but the ones for cataract operations are over 100,000 usually to buy, and the Da Vinci robot, which you saw, is hugely expensive. The dental ones are about 50,000, so a lot of dental schools are now acquiring them. Now, if I was talking to a surgical colleague and I didn't know their level, I would have to find out what was the task they were doing, how was their eye-to-hand control. So with the dental students, I deconstruct the tasks so that I know I'm just looking at their eye-to-hand control without adding any cognitive load, because the understanding of what to do is very different. So I want to make sure that they've got the good eye-to-hand control, and then we start adding in the understanding bits. So it's little stages, and then I know that they'll be able to do more complex tasks before we actually let them loose on a patient. And I think that's what you have to do with a surgical colleague, is you'd have to look at how can we deconstruct the task into small exercises, make sure they can do the eye-to-hand control. Because when I supervise a dental student and I go and look at what they've done and I think, oh, they may have been a little bit heavy-handed cutting that tooth, is that because they didn't have that eye-to-hand control, or they didn't understand how much I wanted them to remove? And with these devices, you're able to separate the tasks into those sort of exercises, which is very useful.
Okay, so I don't know whether you can see the questions coming up, but I think the middle one of those, the second one, leads on very well, because we're talking about the technology, but also communication skills. Having just been at the hands of an ophthalmic surgeon, I have been incredibly impressed by people who can cut eyes and talk at the same time. So in terms of communication skills, is this, so these are technology for, well, you can read the question, clearly help with surgical skills. Do they have potential to help with communication skills there?
Well, that's a very interesting, and dentistry, unlike some of our surgical colleagues, we are operating on a patient that's awake. We don't put them asleep usually. So we have to communicate all the time with our patients. And I do agree that part of the deconstruction is, at the moment, they're not doing the communication skills. You can learn procedural order and make sure you do things correctly. I think that is the next stage with the artificial intelligence, where you will be able to interact with them and ask questions and they will give answers back, etc. But there's other ways of simulating it. You could do the simulation of the patient consult before you do the procedure. So I do agree. And then you bring the whole together. And that's how the airline industry does it. They deconstruct before they bring it all together, so you can fly the aircraft independently.
Thank you for that. Let's go to the first of the three questions, which is from Jonathan Farmer. And he asks, has any research been done with foundation dentists?
There hasn't been much, and I'll be honest about that. A lot of the foundation sort of VT centers are beginning to get haptic devices. Unfortunately, they're not using them in a way that can collect hugely useful data. They're letting them practice on them. But if you're going to collect useful data, you need to do it in an orderly manner. So it's fine and good letting them practice and develop their skills, and they will know themselves if they're improving. But if we want to collect the data and do true research, we have to do it in a more systematic and organized way. I have discussed this with some of the VT areas that have got centers with haptics. So yeah, if you're willing to do some research, I'll be more than happy to help.
Okay, then let's move us on to a question from Anne Begley. Would this be of value in skills testing for aptitude and selection for craft specialties, including dentistry?
No, that's an interesting one, Anne, because there was a period where dentists were constantly at interviews being asked about dexterous skills. Now, the research that we did way back in the early 2000s, before we did our haptic, you saw the big study, we had 144 students. We decided to look at gross and fine motor skills of the students to see what were their ability on traditional gross and fine motor skills, which have nothing to do with dentistry or healthcare, but they're psychological tests, so that we knew the baseline measurements. And then we tested them after they did the training to see an improvement, which it did improve. But when we did the preliminary baseline measurements, we found that dental applicants, now whether it was the ones we had accepted, were way above average. They had far better eye-to-hand control than the average individual. So we had to actually increase the complexity in order to see any differential between them. But we decided we would check medical students, and we found the medics didn't have the same level of eye-to-hand control as the dentist. Now, whether that was the selection criteria, we don't know. But we thought about it, because we then started asking about hobbies. And it seems that people who are attracted to dentistry generally did a lot of eye-to-hand control in their hobbies. And when you think about it, dentistry, is kind of working in like a volume of a tin can, using instruments, that can be quite long and fiddle. So it'd be a bit like trying to pick something out of a tin can with chopsticks. So it's quite challenging. And it seemed to be that of the King's cohort that applied for dentistry, and this is probably true of all universities, that they actually were way above average with eye-to-hand control and chose dentistry because they enjoyed doing that. So the question is, would it be of benefit? probably not, because they're already above average, and we're going to be improving them. I am fully aware, though, that you must see some postgrads who you think are not that good, and some, but we're judging by very high standards. And I do think deliberate practice will achieve the results. Some of us will have to do more deliberate practice than others. There's one area of research that's not been done to my knowledge in dentistry, which is a challenge, and that is some individuals struggle and will always struggle with mirror vision, and some will always struggle with left and right, I'm afraid. There's been research done in surgeons on people getting their left and rights mixed up, but it hasn't been done in dentistry. And because a lot of our work is done in mirror vision, that must be hugely challenging if there is a condition that people will always struggle with getting their left and rights mixed up. But I'd love to talk to you, Anne, about this as well, if you're interested in anything.
So I think we've probably got, I'll just keep an eye on Claire, time for maybe a couple more. So.
Oh, I'm going to answer one from Fiona. Okay. Nice to see you, Fiona, about team skills. The curriculum here in Liverpool, the first 3 years, which is the Common Collaborative Core, is basically therapists with dental students, and they don't know really who's a therapist and who's a dentist. They share the first 3 years and they do work together, and we always pair them off. So one acts as a dental nurse, then the operator, and they swap over. So we actually are effectively having nursing, therapy, dentists all together, collaborative skills, learning and working together. And I think most schools are at least pairing, but they may not mix their dental students with their therapy students quite as much as we do.
Good. And I think the final one, if I can use chair's privilege, is from Andrew Leith, which is around, basically he's asking whether you believe that this will eventually replace phantom heads. And I guess in the world of medicine, the work that we do learning on patients.
Yeah, well, I would say at the moment it's blended, and I wouldn't want to replace it. And I think it needs to be blended. Now, if you've got novice, meaning that they're very inexperienced in an area, I think you should always do the haptics before phantom head. If you're going to be doing for postgrads implant surgery or postgrad endodontics, I'm perfectly happy that they've actually treated patients, and they've, not just phantom heads, but real patients. And then what we do is we haptically enable the cone beam CT scans of difficult cases. So then they practice difficult cases in a haptic environment before they then move back to patients. So that's why there's a different sort of order for novice versus, let's say, competent leading to proficient learners.
Good. I think we need to bring it to a close, and that's been a really, really wonderful evening. And I think for me, one of the things that I will take is that we can learn individual skills and practice them and repeat them, and then build them up into a whole, rather than trying to do the whole from start. It's almost, you need to know what the whole is, then learn the little bits and build it up. So I shall look at medical education slightly differently from here on. Thank you very much indeed, Barry. So perhaps everyone would join with me, and thank you again.
It's been a great honor and pleasure. Thank you, Jackie.
And just before everybody is about to depart, can I just remind you to think about the offerings from the Academy. Firstly, if you're going to do anything when you turn off your computer tonight, is just think about applying to become a member or fellow of our Academy. Have a look at our website and think about filling out the paperwork. There are plenty of people around who will help you with that. The next is to bring to your attention our conference in the summer, Learning Together for Clinical Excellence, and we hope that many of you will want to come along. That's a face-to-face conference. And then finally, to keep an eye on our website for the Insight series. We have some in the planning, and we will keep people notified. So Barry, once again, thanks so much for joining us this evening. It has been a real pleasure and a wonderful event. Thank you.
Great honor. Thank you.